So you've got a disease that's really very well localized to the prostate, a low Gleason score. You're a perfect candidate for what we call active surveillance. That often disturbs patients because they think, wait a minute, I've got a cancer, shouldn't we treat it? And I expect that's going through your mind. And I'd like to describe why you're a perfect candidate for that. So the men who are perfect candidates for active surveillance, like you, have Gleason 3+3 disease. Now, sometimes we'll also include men with 3+4 disease as long as it's low volume. And low volume means the number of cores of those that I took that are positive. I prefer that you have no more than 4 out of 12 positive cores. And if you have Gleason 3+4, no more than 1 or 2. When I take that tissue, we get a small sliver of prostate tissue. It's about 1 millimeter in diameter, anywhere from 5 to 20 millimeters in length. The pathologist will look at that and tell me exactly how much cancer is in the core. And I like it to be less than 6 millimeters. And certainly for 3+4, I want it to be less than that. And these are good indicators for a person who should be or could be on active surveillance. The other thing I do, though, is something called a genomic test. There are a couple of these. The one I use is called the Oncotype DX. What it does is look at the cells, the cancer cells, and does a genomic sort of investigation. It will tell me whether the genetic changes in your cancer are more likely for it to behave aggressively or like a normal 3+3, non-aggressive. The tissue that I've already taken from the prostate, I have in the pathology bank. We'll cut an extra slide, send it to the reference laboratory, and they will look at the tissue that we've already taken out, one that has the cancer. So what they'll do is give me what's called a genomic prostate score, and that score will tell me whether you're in a low likelihood of progression or more advanced, more aggressive disease already, a medium or a high risk. When I say more aggressive cancer, I mean that if I took your prostate out today, we'd find that really it wasn't a 3+3, it was a 3+4 or 4+3 or higher. So it helps validate me having you on active surveillance. And it's the right thing to do because treating your prostate can cause complications to the quality of your life that we don't want to have happen. And the only way to avoid those risks is don't get treated. Now, active surveillance doesn't mean go away, we're good, you're okay, don't worry about this. It means truly active surveillance. And that means I'm going to follow you frequently. You're going to get tired of seeing me. We'll get a PSA every 6 months. I'll get an MRI every year and a rebiopsy in a year. We don't biopsy every year forever. If your prostate cancer doesn't change, we start spreading the time between biopsies and then eventually don't biopsy at all if your PSA remains stable. If, however, your cancer changes, then we'll talk about should we start looking at treating it. And the other thing I want you to understand is that men who we find are very appropriate for active surveillance, if the cancer changes, they didn't burn a bridge. They will do as well when it changes and we treat it as they would have done when they initially were treated. So we don't lose the opportunity for cure by watching you closely. And it's something I encourage you to think about.